be considered getting a breast reduction, and what does it mean when someone says that they've had a mastectomy? Hello and welcome. I'm your host, Dr. Musam Tomene, and signing with us today is Atya Asma, and the feeder interpreter is Caitlin Nair. On Vital Signs, we focus on cosmetic and reconstructive plastic surgery, and coming up on the program, we'll speak to well-known author about her journey with a breast reduction, as well as breast reduction surgery. We'll take a look at an insert produced by Wandile Mfukeng. He spoke to a 27-year-old transgender woman about her journey with gender identity and her surgery as a transgender woman. We'll speak to Plastic and Reconstructive Surgeon about the most common plastic surgery procedures that he has to do, as well as transgender women to men transformations that they do. We'll also speak to head of the Helen Joseph Breast Care Clinic. That, of course, will be looking at the benefits of breast reconstruction after mastectomy. Remember that you can be a part of the show by asking the guests that we'll have on the questions that you have in your mind by simply sharing the views on what we're discussing. The number to call is 011-714-5861 or 011-714-5877. You can also share your thoughts with us on social media using Twitter at SABC Vital Signs or our Facebook page, SABC Vital Signs. Vital Signs will continue right after this ad break. Stay with us. Welcome back. This is Vital Signs. Now, breast reduction surgery is meant for women who have large breasts and want to resolve this issue, such as chronic neck, as well as back pain, as well as shoulder pain that may require them to take pain medication. Other issues such as chronic rash underlying the skin irritation areas under the breast, and of course difficulty into fitting into bras as well as clothing are some of the other issues that contribute to this. Well-known author Sihle Bolani joins us to share her breast reduction experience, as well as find out from her what led her to doing this type of surgery. Good morning. Thank you for joining us, Sihle.
Thank you so much for having me.
So let's talk about the surgery. I mean, a lot of people hear about it, a lot of people don't know about it. What led you to finding out about breast reduction surgery, and what made you want to get it?
Well, I had struggled with very large breasts from my teen years. I was a late bloomer when I was in high school, but once they started growing, it felt like they just never stopped. And so there's a number of reasons why I wanted to do something about it at some point. And those include, for instance, the discomfort that comes with having very large breasts, the backache, the neck ache, just lifestyle issues, for instance, going to work out, needing to wear double bras at the gym. There were just so many issues around that. It's also incredibly difficult to find nice bras when you have larger breasts. So there were, it was just an amalgamation of all of these types of issues. And obviously, as well as the expense of, having to wear larger bras. But the other thing for me, which really leans more towards the societal GBV angle of it, was just having the experience of being sexualized from a very young age. And so I became very self-conscious about my breasts. It affected my confidence. And so once I started working, I really decided that this is something that I wanted to explore. The first time I had a consultation with a plastic surgeon was probably, in 2014, just to get an understanding of what the procedure entails, how much it costs, and whether I'm a viable candidate for it. But it was only really last year that I eventually decided to take the plunge, and I went and I had my procedure done. And it honestly has been life-changing.
So what goes into this consultation? I mean, we've described all the, symptoms and all that sort of stuff that someone would, need to experience. And a lot of it is quite subjective because, someone having a double G-cup breast versus someone having a C-cup, they could all experience the same sort of pain. So the consultation in itself, what went into it?
So my surgeon was Dr. Brian Munaisa, and in my consultation with him, he needed to understand a few things. So the first thing that you do is to explain what it is that you want to do and why you want to do it. So at the time, I was an E-cup, and I explained to him that I really just wanted to have breasts that would be get up and go breasts, as I call them. I was sick and tired of wearing bras, but also I wanted to feel more comfortable and alleviate the pain that I was feeling. So he then pulled me into a consultation room where he then looks at the breasts. He looks at how much you have, how much is possible to take off in terms of the size that you want. Is it possible? He also explains that, they cannot guarantee that you'll get the size that you want, but he will do his best to try and get you as close as possible. He also explains that there is a maximum amount that they can remove from your breast. So we went through all of that. And then he also talked me through what the pros and cons are, what are some of the risks involved with undergoing the procedure. And then he also explained how he's going to do it. So where is he going to make the incisions? Where is he going to take out the excess that you want to have removed? What is your nipple going to look like? The risks around nipple sensation after the procedure, because there is a possibility that you may or may not have sensation in your nipple after that. So it really was very informative. And for me, having a surgeon to patiently explain all of those processes to you, and also he led me to other resources, international resources, where I could read up more about breast reduction surgery. So they gave me a lot of confidence. But I also spent a lot of time watching YouTube videos, just to watch people who had been through the experience and shared how their recovery was, what their experience was, so that I had a better understanding of what to expect. Because it can be quite anxiety-inducing to undergo a procedure like that, because you don't know what to expect.
Look, sounds quite interesting, and I think it's such an important topic to cover, and having someone like you to come on and really just give a personal perspective and not just this big medical thing that a lot of people just see on TV and never see as something that they can do has been really eye-opening. And I hope someone that's been dealing with all these issues can really pick up from this and maybe start that journey as well. Thank you so much, Sihle, for joining us today and really having a chat with us around what breast reduction was like for you. We continue this discussion, of course, around plastic and reconstructive surgery with Dr. Brian Munaisa about the most common plastic surgery procedures that he does. Stay with us. Welcome back to Vital Signs. I'm Dr. Musamtombeni. Now, plastic surgery is a surgical specialty involved with both the improvement as well as the improvement of just general appearances of a person, as well as the reconstruction of facial and body tissue defects that may cause illness or be caused by birth defects that they might have had. Now, plastic surgery restores and improves function as well as appearance. We're joined by Dr. Brian Munaisa, who is an internationally renowned plastic surgeon whose passions extend beyond the usual nip and tuck. He joins us to discuss the different types of surgeries, rather, that he does, as well as breast reductions. Good day, Doc. Thank you for joining us.
Thank you, Dr. Musa. Thanks for having us on your show.
So, when people think and speak about plastic surgery, it's always this, oh, you guys just do noses and you guys just do bums. What are some of the common procedures that you guys do in plastic surgery?
Okay, so the first thing I must clarify is with the name plastic. We don't usually put plastic in your body.
Ah, important.
What we do is reshape your body, much like you can reshape plastic.
Okay.
So we can do anything. We're from the ears to the toes. The most common procedures in my practice, my practice is mostly black women, about 80–90%, and their biggest concerns tend to be around body contouring. So breast reduction, breast lifts, breast augmentation, a lot of work around the tummy area, whether it's liposuction, a tummy tuck. And of course, you said bums, but the bums are a big deal. The Brazilian butt lift is growing in popularity all the time. So those are the most common procedures. But you find, if you operate on someone in their 30s and this is their complaint, then, as they get older, then they will start worrying about their face and facial rejuvenation. We do a lot of non-surgical stuff on the face. We do a lot of skincare. And then what's currently also, gaining traction in the face is fat grafting.
Okay.
We do a lot of fat grafting. We do a lot of blepharoplasty, which is eyelid surgery, eyelid rejuvenation.
Okay.
Because just by rejuvenating the eyelid area, you just look so much fresher, so those would be the main
So it seems plastic surgery has got a wide range of things that it does. And I mean, the I don't want to call it a negative, but the perception that's been in the public for a long time is that it's very aesthetic. People just go there to go do, their bums and eyes and boobs and, all that sort of thing. But of course, it's beyond that. What kind of reconstructive surgeries do you do?
In terms of reconstruction in my practice, I think the biggest things that I do is pediatric hand surgery. So these are kids who are born either with extra digits or missing digits or duplications of digits. And then we fix these, we either build them a proper thumb or we take away the extra thumb, things like that. We do a lot of ear surgery in children, a lot of cleft lip and palate. I think that's one of our biggest, that's what plastic surgery is generally known for in the reconstruction. And then in adulthood, I do a lot of breast reconstruction, a lot of post-cancer excision reconstruction, so skin cancers on the nose, on the face, a lot of that is done by plastic surgeons.
Okay, so a very wide specialty it seems.
Yes.
So let's get back into the topic of the day. We're speaking about breast reductions and just breast augmentations in general. Is there a difference in breast augmentation and breast reductions? What's the difference?
So breast augmentation is where you want to make the breasts bigger.
Okay.
And often you can use fat or you can use a silicone implant to do that, okay? The fat, you often have to do multiple procedures. The silicone implant, it's one of the reasons plastic surgery got such a bad rep over the years. There were issues around its safety, etc. But, the current generation of implants are exceptionally safe, okay? And then a breast reduction is almost the opposite. This is where the person has been genetically gifted with too large breasts, and these weigh on them. They cause back pains, they cause shoulder grooving, they get rash around the breasts. Your previous guest, Sihle, spoke about her experience with me, and the benefits of a breast reduction are beyond comprehension. These are people who often tend to be a little bit socially withdrawn because, in normal conversation, people aren't talking to them, people are talking to their breasts. These are people who can't play sports in high school because the breasts are so big. And once you do this procedure for them, you see a whole new person emerge. And so I really think breast reduction is actually much more of a functional procedure as compared to augmentation, which is maybe cosmetic. I think breast reduction is something that must be seen as a medical procedure for people who need it because their breasts are too big.
So what goes into deciding whether someone can have this breast reduction or not? So it becomes quite a subjective thing, does it not? Where I am a woman who is a C cup, but I feel my breasts are too large, and therefore I want them reduced. Is this a scale or spectrum in which you decide whether you can or should be reducing someone's breast? Or does the cutoff become something that you can say, right, cool, anyone over a C cup gets reductions, anyone under doesn't?
That is a great question. Plastic surgery is about you, the client. It's about what you want, okay? So ideally, we would do the procedure for someone who we don't think is crazy. If we think that you're a normal, mentally capable person who wants to make their breast smaller, who am I to say no to that?
Yeah.
Okay? In terms of medical indications, what we look at is the size of the breast, the expected reduction. Last week, I did 2 patients who the total reduction was 4.8 kilograms. We took off 2.3 kilograms and 2.1 kilograms because, the breasts aren't always the same size. And then the other one was about 3.5 kilograms. So these are people who literally had the weight of the world on their chest. So that's a medical indication. But once you've gone past the patient's desires for the procedure, then you have to look at the safety of the procedure.
Okay.
So you would avoid, because the patient, is healthy when they come to see you, and this is elective surgery, you would avoid operating on patients who you might leave sick after the procedure. So often these are patients with higher BMIs or very obese patients. They tend to heal poorer. We don't do plastic surgery at all in smokers because, plastic surgery is all about the blood supply. And smoking can turn a great result into a disaster. So we don't want you to smoke before or after surgery. We also counsel patients. This is something I must tell you. We counsel patients, especially in our community, about traditional medicines. Traditional medicines before surgery will make you bleed more. But everyone believes that they will help you heal better. And there I am now stuck and you're bleeding everywhere. And this can actually be quite unsafe. So those are the kind of things we look at from a safety perspective. If you've had a recent pulmonary embolism, we might say not yet, give it another 2 years, let your blood, your vascular system, recanalize properly, So really, it's a combination of clinical factors, which is the patient's desires in plastic surgery, and also our ability to do the procedure safely.
So, Brian, we are obviously having a plastics discussion, and it's going to be about cosmetics, and people will call in. So let's take a break from our discussion around breast reduction and go to Getty on the line from Heidelberg. Hello, Getty.
How are you?
We're well, thank you. How are you today? What's your question for the doc?
I was asking about the price and the procedure of a facial plastic surgery.
You want to find out about what exactly?
Facial plastic
The price
surgery.
and the procedure.
Okay, so the types of procedures that you would do on a face. Can you just give us a broad outline of the type of procedures that a lot of people would come in for in terms of cosmetics?
Sure. So facial plastic surgery, a lot of what we do in the face, in black women, especially like the collar, we don't age the same way as other populations. So you find we have a lot less wrinkling, but we have a lot more of drooping of the tissues.
Okay.
And we get hollow in the cheeks and full at the bottom. The face becomes more square. So we do a lot of facial fat grafting to re-triangulate the face, to give you that youthful triangular cheekbones. And then like I said, we do a lot of eyelid rejuvenation. We do the odd facelift, or in my practice, the odd facelift in black patients, but mostly facial fat grafting and eyelid rejuvenation. We do a lot of nose surgery, rhinoplasty, as you said, although we find that people are, because of stigma, people are not as keen for that. Even if they don't like their own nose, people feel that, they'll be judged, for having that. So we do the full range of facial plastic surgeries. And in terms of costs, it's very difficult to say without having seen the person. But I think in general, it should range from about 60 to maybe 80, 90,000 rand. 60
to about 80, 90,000 rand for whatever it might be. And of course, all this stuff sort of requires a consultation so that they are making the right thing. They are fixing the right thing. They're not going to guess on TV. Brian, back to breast. What are some of the risk factors that go into a surgery like this? What are the big things and the big flags that you need to look out for if you're going to operate on a patient that makes you say, maybe let's take a break? I know you mentioned smoking.
So smoking is a definite contraindication. Plastic surgery is being described as a battle between beauty and blood supply.
Okay.
So if you smoke, we cannot operate on you. The second one would be being very obese. A lot of people come and they think plastic surgery is a weight loss procedure. It's not. It's a body contouring procedure. So we can improve the shape of your body. We don't necessarily focus on getting rid of all the fat that we can. So for example, with liposuction, we can only suck a maximum of 4 liters in a session. Okay. So you can't come to me and expect weight loss, And also, people with higher BMIs tend to heal poorer. So those would be the 2 first ones, okay? After that, you'd look at the patient's kind of mentality, the patient's mental state. You'd avoid operating on narcissistic people. Avoid operating.
So what goes into that? So you're a plastic surgeon, so generally you cut. That's your story.
Yes.
But do you involve other specialties? So at your practice or in practices, do plastic surgeons sit and say, cool, I've got a psychologist and a psychiatrist and whoever else that I need in my practice to sign off on every breast reduction or every nose job? Or
Not everyone, not every single one. There are procedures where you will definitely have a psychiatrist sign off. Patients who've had psychiatric conditions or patients who are transgender patients, for example, those need to be signed off by a psychiatrist and in the case of a transgender, an endocrinologist as well. But if someone comes and they have a history of high blood pressure, maybe they've had angina before, I would send them to the physician to clear them and see and agree that their body can tolerate the 2 or 3 hours of surgery before we operate, So it's, and in terms of the psychology, a lot of it has to be your own assessment of the patient. So for example, if someone comes, like you mentioned, someone with nice, beautiful C cup who comes and says that they want a reduction, I have to look, and if I think the breasts look great, I have to start looking at the person's mind and seeing, is this person going to be happy with the reduction, or are they expressing other problems in their life? So for example, one of the great contraindications is a middle-aged guy who has either lost his job or getting divorced and wants a nose job. For some reason, men, when we're depressed, we tend to focus on the middle of our face, and now we blame everything on this nose. And if I can't fix your nose, and or if I fix your nose, but I can't get you your job back, you're going to be angry at me. You're going to say, I messed it up.
Yeah.
You understand? So because you came in healthy, it's actually always easier almost to not operate. You know, if I have any reason to not operate, then I avoid a lot of problems. And I'd rather have a patient be angry at me for not operating than have a patient be angry at me for operating.
Look, we'll continue this discussion. Of course, we'll be looking at other bits of plastic surgery. Some of them you've mentioned already. But after the break, we'll speak to the head of Helen Joseph Breast Care Clinic at Helen Joseph Hospital, of course, Professor Carol Ann Ben, about breast reconstruction surgery. Stay with us. Welcome back to Vital Signs. Now, many women who have had a mastectomy to remove the entire breast, of course, and to treat or prevent breast cancers that have that option, are having this idea of thinking about maybe having that removed breast rebuilt. Now, women who choose to have their breast rebuilt have several options for how that can be done. We're joined by Prof. Carol Ann Ben, the head of the Helen Joseph Breast Care Clinic at Helen Joseph Hospital, to speak about breast reconstruction. Good day, Prof. Nice to see you again.
It's great to see you.
Good. So, mastectomies.
Yeah.
Who gets a mastectomy? I think it's such a term that, you know, a lot of people hear, but no one really understands what has led to you getting a mastectomy. So let's go through that.
So I think today we need to realize that we spoke a little bit earlier about so many people, we're seeing so many advanced breast cancers. So there are very few actual indications for a mastectomy. It's an inflammatory breast cancer, big, red, hot, inflamed breast, all get it. Paget's of the nipple, where the nipple's red hot, and we see the change, the ulceration, or when you have cancer throughout your breast. Otherwise, if you've got a big cancer, and we want to encourage people to come in, if you melt the cancer down and you make it smaller on oncology, today in the private sector, about 70% plus of people get breast-saving surgery. You know, you and I know that in government it doesn't happen. It doesn't happen for a couple of reasons. Sometimes people think they want to take their breast or both their breasts off. I always say you don't need to. Cancer doesn't jump from one breast to another. And the next issue that we need to realize is that people are fearful. So they think if they have a mastectomy, it replaces their need to have either chemo or radiation, which it doesn't either. So I think you bring up such an important concept. This concept you spoke earlier with Brian about teams, and you spoke about psychologists and psychiatrists. I think when it's dealing with a breast cancer and choices around surgery, it's important to have a team look at the options. And again, look at all the options to the patient. And we usually say less is more, and if you can get away with one operation, better. Because as you and I well know, people then don't come back. They're like, well, I've had my breast off, I suppose I can cope with it. And I think the female form is so important. Breast reconstruction is for women. It's not for their partners. And we used to think that maybe they didn't feel good with their partners, but actually they just don't feel good about themselves. And that's why this topic is so important. There are many options. Take fat from the tummy, you can take muscles from the back, you can put in expanders and prostheses. But if you can avoid a mastectomy in the first place and do a small operation, or like you mentioned earlier, take a cancer out through a breast reduction, far better.
So now that we've gotten to a point where we've identified this cancer, it's all over the breast, and we then have to do a mastectomy. How do we reconstruct that breast? What goes into reconstruction?
So you can reconstruct immediately or delayed. So the nice thing to know is that as long as you're taking a cancer out with clear margins, today you can save the skin and you can save the nipple. Okay. Then how do you reconstruct the breast? We can take the fat from below the breast. It's called a Goldilocks type reconstruction. We can take muscles from the back. That's called a lat, or from the tummy. That's a tram or a diep. Or we can use prosthetic material. Now, unfortunately, at the moment in government, we don't have a lot of access to that. We used to about 10 years ago. And again, Brian mentioned this concept of fat filling. What we can do is do the mastectomy, come back after the radiation, just fat fill to increase the size of the breast tissue. So there are many options, and I think people mustn't be scared to ask. Before you rush into surgery, understand your options before you go in. So important things. 65% of people who get breast cancer have no risk factors. The surgeon shouldn't cut out tumours just or lumps because they're there. You want to do a needle biopsy, know it's a cancer, and come up with a multidisciplinary plan. And that's why our radiology meetings are so critical, because we sit and have a look and everyone works together and say, this is where the cancer is, these are the options, and then we come up, and I really value them hugely, what we have at Helen Joseph. We come up with a plan, so the patient is participating in it. I think we've moved away from vertical medicine into horizontal medicine. We must understand the importance of the patient, and by doing that, we will make people want to access our services better. We have this less vertical medicine, people scared, not wanting to come in, to really participate in their health care.
From your experience with women that choose not to have reconstruction, what goes behind the psychology of that?
So it's very interesting. So what often happens, and I particularly see at Helen Joseph, if people elect to have a mastectomy, they often elect to have both. They want the symmetry of having both breasts off, and then to put, and we have things from knitted knockers to a variety of different prostheses, external prostheses that we put in the breast. But you can't say it's an age issue. Sometimes it's a cancer issue, and women handle it differently. Some people are, for them, their breasts have betrayed them. So take them off, take them out, and I'll deal with the concept of reconstruction down the line. So the issues of oncology, psychology are probably the least understood but most important in managing people with their choice around reconstruction or not. We have counsellors at our Helen Joseph clinic. A lot of them have had mastectomy, some have had breast saving, but they've been through the journey, so they can talk to patients about pros and cons and how they feel. But remember, each person's an individual. Their choice, their right, and an understanding of their options.
The difference between doing a reconstruction and patients that come in having a small cancer, and I think you mentioned a little bit earlier on where you do a breast-saving sort of recon.
Absolutely. We do more and more at Helen Joseph. So what we do is small parenchymal flaps where you just take out the cancer, move a bit of tissue around. Sometimes we do more oncoplastics where we do a breast reduction technique with a plastics team who are at the clinic with us. And again, it's about safety. As you well know, we discuss where the cancer is in radiology, what the options are, and we try and do smaller, safe procedures because most of the patients are going to require radiation anyway. And what we want is they probably are not going to want to come back for more surgery.
No.
After gone through chemo and then surgery and then radiation, do less, smaller, and so they can move on to the life after survivorship aspect of cancer.
Now, a lot of healthcare providers will speak to the difficulty of a patient in that a young patient will come in saying that they've got breasts in more than one part of the breast. So they will want a breast conserving surgery to be done, but the option for that is not necessarily something that's available. How do you manage a patient like that that can potentially get a reconstruction but doesn't want to because they'd rather have a breast conserving treatment?
So if we can breast save, we'll always breast save, and what we will do is take time because breast cancer doesn't run around your body in 24 hours. So we often say to the patients, come back to the clinic, discuss again, bring your family in, go over all the options. So we're quite fussy about that. I think the concern is, what you mentioned, is when we see these youngsters, and the lovely lady who did my makeup so nicely, we were talking about how many young breast cancers we see. Under 30, and you know what you see, and these are big DCISs, big cancers, where we can't often breast save, and that for me is quite traumatizing. So we work quite well with the Plastics and Recon team to work out what to offer these youngsters, because it's hard for them.
Breast reconstruction, after you've had a primary breast cancer before, and the follow-up of that patient, can the person get a new cancer in the reconstructed breast?
That's a lovely question. So if you're taking out cancers with clear margins and you're following the right oncological rules, such as radiation for breast saving, taking your endocrine treatment if your cancer is endocrine exquisite, the pickup rate and the chance of getting it is very low. So in our units, we see it as under 1 to 2% in the Mill Park unit, and it's maybe sits at 5 to 7% at Helen Joseph. It's really around compliance, access to radiation, and it's small. It's like blonde shouldn't be in Africa, so you take out a funny mole on me and it comes back as a melanoma or something atypical. I can't take my skin off, but I need to keep a close eye on my skin going forward. So that's the concept. So people mustn't be scared of the second cancer. They must just go bit by bit, because you can always come back later and do risk-reducing surgery. So rather do smaller, cope with it, get through the process, and then make your decisions going forward.
This idea of young people getting these cancers, more and more often we're seeing younger and younger people getting cancer, yet when we speak about screening for breast cancer, it's that old school sort of feel that, you know, pop in once every 2-ish, 3 years if you feel like it, check your breast. What is the current guideline with respect to if you think you might have a cancer?
So I think what we need to know is you don't have eyes on your fingers. That's why we love the radiologists. So you don't have eyes on your fingers. If you're under 35 and you feel a lump, you come in, it'll be assessed. And I always say to the students, these are open access clinics where people are coming because they've got a symptom. So they deserve, and as you well know, our system at Helen Joseph of colour coding, red if we suspect cancer, yellow if we're not sure, green, we can't really find anything. It means then the radiologist is your best friend. So they're going to do the sonar and say, is this a concern or not? Obviously, when you guys are not quite sure, is it a fibroadenoma or something, you will do a core needle biopsy and confirm, because we do see triple negative breast cancers in youngsters. Over 35, the patients who come in get mammograms or ultrasounds, and we screen them depending on their breast density, yearly, 2 yearly, or 3 yearly, but we will triage the patient depending on what they come in. But you bring up such an important issue. You're young, you pick up something, you don't think it's a cancer. Please no, don't be scared. Rather come in early, let it be assessed, and if it's a problem, we can manage it.
Very important notes I think we're getting from here. And one of the big things that a lot of people like shying away from is this issue of treatment. So with regards to the number of people that you diagnose at the clinic, and I think maybe we can extrapolate it to make it a more national thing. When you diagnose a patient to the outcome at the end of having someone having had the surgery, radiation, as well as plus minus the chemo or endocrine treatment, what do those numbers look like? Are we getting people that are running throughout the whole spectrum, or do people just fall off along the way?
So that's such an important point. So if we look at the stats of the patients we see in the clinic, they actually resemble exactly what our population is for Joburg. I see about 7% under 25. We see lots of elderly people, which I always find a surprise because you think that they can't access care or don't come in. So about 9 to 10% older people. We see people under 35. So the navigators are crucial for ensuring people continue their treatment. And we have quite a lot of durability in our breast clinics with people going through systems. We had a problem with Pfizer at Charlotte and access for a while, where we really battled to get people into access. But the system, particularly at CMJ under Prof. Demetrio, is very, very tight at the moment. So the booking times are under 2 weeks. And as long as the navigators are encouraging people to continue with their chemo, because it's a bit like an extreme event, it's hard, we will then see them back in the clinic. So it's that encouragement and support along the way, and it's a good team and it seems to work. So very important. We still see about 60% locally advanced cancers, which is way too high, which is why programs like this are critical to get out the please don't be scared and please come in message.
Please don't be scared and please come in. The words of Prof. Ben really speaking to the idea of breast cancers. And of course, today we've covered what happens with respect to reconstructions. Thank you so much, Carol and Ben, for joining us today. And of course, we will continue to see you at clinics and all the clinics that you continue to run. Going for a quick ad break, and we'll continue our discussion right after the ad break. Welcome back to Vital Signs. Now, a decision to undertake gender reassignment is made when an individual feels that his or her gender at birth does not match their gender identity. This is called gender dysphoria and is recognized as a medical condition. Radio host, TV presenter and content creator Roxy Msizi sat down with us to share her experiences with us. Take a listen.
I was born or assigned male at birth. And I grew up and transitioned to be the woman that I've always been, you know. So at a young age, I always knew that I was a girl but unfortunately I was addressed as a boy, so it didn't make me feel comfortable. So, but I was trying to explain myself until I think I was 18 years. That's when I heard about the word transgender. Sihle Bolani, and I welcome you all to Soweto FM, Soweto Family Media, the voice of Mzansi and abroad. Igama lami nguRoxy Msizi, or Miss Roxy on the rocks.
Radio and TV personality Roxy Msiza from Shawelo in Soweto sat down with us to talk about her journey with regards to being a transgender woman.
I've always prepared myself from the young age. I'm going to grow up, I'm going to be a woman, even though I didn't know it was possible right here in South Africa. And then when I started and learned about transgendered women, that's where I found about hormonal replacement therapy, the surgeries that are being done. I started transitioning 2020, and now it's 2022. It's almost 2 years since I started.
She explains that the transgender procedure is a very long process that requires a lot of intervention before doing any type of surgery or body changes.
I started with getting enrolled to see a therapist and a psychologist. There's a clinic called Lutando Clinic in Bara where I attended sessions. I think I attended 5 sessions, but most of the time it takes longer. They just want to see your mental state of understanding yourself and how you identify yourself. Are you sure that you are this type of person? They ask questions that are uncomfortable though, but it's the process. And then I got a letter that permitted me by then, because they needed a letter for me to enroll to HRT, hormonal replacement therapy. So I started at Endocrine 2020. Okay, when you start with hormonal replacement therapy, they start giving you hormones. Okay, it can be pills, it can be an injection, depending on what you prefer. So when you start, when I started personally, I grew up a breast, got feminine. I didn't develop hair on my face, and then yes, my body just gained hips, thick thighs. And what can I say? I just became a woman. Simply in a nutshell, my skin became softer, yeah.
Through private donors, Roxy has applied to do an okitomie surgery so that she can continue with her transgender journey.
The surgery that I've applied for is okitomie surgery, which includes of the removal of testosterone to suppress the testosterone in my levels, in my hormones, so that it cannot be produced anymore, so that I'll be able to get off hormonal blockers, which are the pills that blocks the hormones or that creates testosterone in my body so that they can make me masculine.
She feels that South African health workers should be more open and understanding when it comes to transgender people that need access to health care.
Most of the time in public hospitals, you'll go there and say that you want to transitioning. They'll tell you that they don't know what you're talking about. Where else you are at the right place at the right time, the person that you're talking to is the relevant person who is supposed to assist you. So they delaying the process and making people to get into that state of having depression and those kind of things. Because I still remember when I wanted to start transitioning, I went there. The lady who is, I would say, an administrator or someone who registers us and gives us the feedback so that we can see the doctor. She just chased us out and said there's no such thing in South Africa. Where else there were trans people who referred us to that particular endocrine clinic.
The transgender procedure is a very personal journey, according to Roxy. She encourages those that want to do it to take it step by step and not rush into it.
Even if when you start, they tell you that your journey is different from another person's journey, because even the results are not the same. You might take, for someone else, it might take only 3 years to get to that full maximum of, if I may say, getting to be a woman that you are. For some people, it can even take 10 years getting to that ideal woman that they want to be. So it's a very personal journey.
Sex reassignment surgery, also known as gender reassignment surgery, and several other names, is a surgical procedure by which transgender persons' physical appearance and function of their existing sexual characteristics are altered to resemble those socially associated with their identified gender. We're still joined by Plastic and Reconstructive Surgeon Dr. Brian Monaisa, and in this segment we focus on sex reassignment surgery. A very important topic in that it's becoming something that a lot more people are discussing as more and more people identify differently to what we've previously known. Yes. So how common in practice are you seeing or hearing people coming in to find out, even if it's just questions before they get into the process of potentially having the surgeries?
Well, like you said, I think, the world is becoming more open. People who previously were afraid to come forward and look for help or even just to find out information. They're coming out much more now. And I think this is a good thing, because as you said, it's called gender dysphoria. You are literally unhappy every day in your body.
Yeah.
You look at yourself, you feel like this is not you. That must be a terrible way to live. So I celebrate the people who want to take the step. And we get quite a fair amount of people coming through. In my private practice, I get a lot of referrals, specifically from a lady called Dulcie. She runs a medical center that does a lot of gender work. I think she's one of the leading lights in that. So working with her, we do quite a lot. That said, it's not the easiest surgery to do. Gender reassignment, we divide it into basically initially the top and the bottom, which is the breasts and then the genitals. But if you look at countries like Thailand, they take it so much further, where they're shaving the Adam's apple, they're shaving the cheekbones. So there's a lot involved in it. But in my private practice, I do a lot of mostly top surgery. And I have to say the patients are extremely happy with the results. And that's why I keep doing it. I think sometimes you have to be able to look at things from the person's point of view. And what we see is that these people really do want the help. And by helping them, we greatly improve the quality of their lives.
Now, you've spoken and alluded to it, this idea of, a spectrum that exists with regards to the number of surgeries or the surgeries that you can do for someone that has got gender dysphoria, where you've got top surgeries, bottom surgeries, but do you find a lot of people just opting to have one or the other? And are there a lot of people that move and want the complete surgery where the top and the bottom are all reassigned?
So a lot of people only want the top surgery.
Okay.
And I think a lot of it has to do with the society that they're in. So having the breasts, as someone who, like the previous guest, Roxy Msiza was saying, for her, being feminine, being a woman, when people see her, is very important. So, she can see she's got her breasts, her face has been feminized probably from the hormones, and she looks a lot happier. So I think a lot of it is top surgery. The other thing about it is also bottom surgery or genital surgery is a lot more complicated. It tends to have a lot more complications. So even the surgeons who do it limit the number of patients that they would do in a year, and try and carry one patient through successfully rather than doing 10 and having 8 problems, because you want to help people.
So what goes into a genital reconstruction? So I think if you could explain it on either end, so male to female or a female to male, what goes into making the reassignment happen?
Sure. So if you're looking at going from male to female, a lot of the times this is technically of the two probably the easier surgery. You would deglove the penis and keep the skin of the penis. You would then take the head, which is quite sensitive, and make sure that you keep the nerves and the blood vessels attached, but shorten that. And the head would now become the new clitoris.
Okay.
And then you would invaginate and use the old skin to make the vaginal canal.
Okay.
So technically that's a lot easier than a female to male, where, with a female to male, you have to bring in extra tissue.
Okay.
And what we do then is we either take tissue from the arm or from the thigh, we roll it up into a double tube. So the one tube inside is for the urine, and then the other tube is the actual penis. Then you have to attach that to the blood vessels and the nerves in the genital area, And then, of course, there's issues around the security of the blood supply because, you've had to reattach it. A lot of the times where the patient's initial urethra and the reconstructed urethra meet, there's leakage. And of course, then there's function, because unless you put a prosthetic stiffener in, the patient is unable to get an erection.
So, I mean, let me ask that. How do you grade a successful female to male reassignment?
So I think the grading in plastic surgery is always patient happiness. Okay. So from our side, we would look at our technical capability to do it. And in that sense, whatever procedure you're doing, if you're having less than 3% complication rate, that's quite okay.
Yeah.
And then you want the patients to be happy. So I've seen patients being unhappy with the penis being too large after surgery, or the fact that even though it looks great, it can't stiffen. We haven't put in a stiffener. Then you have to come back and look at putting in an inflatable rod that would then allow them to get an erection and have sex. So a lot of it is really just about the patient's happiness. That's kind of
which I guess is a good thing. When patient happiness is the scale that you use to measure success, I think we have a good time. All right, we've got a call here, and this is Anonymous. Good day, Anonymous.
Good day, how are you?
Very well, thank you. What's your question?
Yeah. My question is, I think I partly heard the doctor speaking about penile reconstruction and erection, but my volume was off, so I didn't actually follow the whole story. Do you also do that? And what is the cost for such an operation?
Okay.
Do we do it all in once, or do we do it first the reconstruction and then the erection story? Or how does it work?
Not a problem. Thank you. We've got your question. A question around penile sort of reconstructions. I think maybe let's get into either way that you could go, where you've got, penile reconstructions due to disease or injury or whatever it might be, but also reconstructions that are cosmetic.
Okay, so, I think a large population in South Africa, unfortunately, we get penile trauma from initiation schools. That is often one of the causes where people come back. And I don't know enough about the initiation school culture to say what the problem is there, but we do get a lot of complications coming from there. Another cause would be, penile cancers, where having the cancer cut off resulted in a loss of significant amount of tissue. And what we try and do then would be to reconstruct the penis for you. It's a multi-stage procedure. I think that's what the gentleman was asking. It's technically, it's better to do it in stages because then you can make sure each stage is done well. We would bring in the extra tissue, join it to the existing blood supply, try and find an existing nerve that, we could reattach the tissue to. Unfortunately, there is no other tissue on the body like the penis. So, there are limitations to the sexual satisfaction that you'll get from it, the ability to attain an erection. But a lot of the time, what the guys want is to be able to stand at a urinal and pee normally, after, for example, having had the penis amputation or something. So a lot of the time, people would be happy to just have a penis there that they can pee out of. And then, of course, there are people who want more and more. So that would be under the reconstruction.
Yeah.
Then there is a growing segment where people are looking at penile enhancement.
Okay.
The same as maybe ladies want to enhance their breasts. Guys are looking and saying, I also want to enhance my penis. And the two things we would look at there would be the length and the girth, and also the quality of rigidity, how hard your penis can get. So the quality of the rigidity is quite easy to address. What we do is take your own blood. We take the platelets out of the blood. And the platelets are the cells that initiate healing and tissue regeneration. So by injecting those into the penis, we encourage the tissue, the penis, to regrow some of its own tissues. Okay, so that helps a lot with that. But then, in terms of enhancement in size, the length operations are really, they're not great operations.
They're not great. How much do they generally cost? So if someone's looking very quickly...
80,000-90,000.
80,000-90,000 Rand to get your enhancement. If you're looking for an enhancement, or if you're someone that has had some trauma or cancer or something along those lines, to get that reconstruction to be done. Well, thank you so much, Doctor, for joining us today and really discussing plastic surgery. A lot of people will agree that it is not just about breasts and that's the end of it. Quite a large field that, of course, addresses a lot of issues. Thank you so much for joining us today as we discuss what we discussed on the show. And this is Vital Signs. Don't forget to look after yourself and manage the pandemic as safely as you can. From me, Dr. Mosamtomeni. See you again soon.